And today's topic is supporting sepsis compliantly coding healthcare's favorite moving target. And I want to mention I've had the pleasure to work with Christy for the last 6-7 years. And Christy's a senior consultant, and she's got over 20 years of industry experience. She is responsible for the development of web-based and instructor-led training materials. She does a lot of in-person training with ICD-10, CM, PCS, CPT, as well as she's active in doing a lot with our auditing department. She's performing DRGs and APC audits. Christy has an extensive background in coding education and consulting, and she's also a national speaker on topics related to ICD-10 and CPT coding, as well as code-based reimbursement. And Christy also has, if you haven't seen, she has a Coder Coach blog. She feels very passionate about mentoring new students and future coders, and so we encourage people to take a look at her Coder Coach blog. And she was also the proud recipient of the 2011 AHIMA Triumph Award for Mentoring. So at this point, I'm going to turn it over to Christy, and I'm going to let Christy, you take it away.
All right. Thank you, Kathy, and welcome everybody to today's webinar. I thought I had the best quote for today coming up, but I think Kathy just said it, which is relax and have a good time discussing sepsis. I don't know that relax comes to mind when I think about coding sepsis. I think my blood pressure usually goes up, and I think that's probably where everybody else is too. Just to kind of go over what it is we're going to talk about today, I am going to start at the beginning, the very beginning. I don't know about you, but with all of the articles that have come out about sepsis over the last year, not just with Coding Clinic, but also in the journal from the American Medical Association and a lot of other publications about the new sepsis criteria, we're going to go back to basics. So hopefully that won't be too painful for those of us who've been coding for a long time. We are going to compare the current sepsis and the current sepsis definitions to the sepsis 3 definitions, and if you don't really know what that means, we're going to go over all of that. I am going to go through a couple of sepsis coding scenarios, and we're going to apply those coding guidelines, but we're going to talk more in depth about some of those issues that Kathy was bringing up before the webinar. Some of you had written into the chat window that you're having issues with supporting the clinical piece of sepsis and, you know, the way that physicians document, and hopefully we'll be able to address all of those things. It was nice to see your comments because they're very much in line with what I plan to talk about today. And we are also going to take it one step further. I've worked with our auditing team to kind of see what some of the things that they're seeing are and identify some strategies to kind of help apply to fix some of the, maybe not fix documentation issues. I don't think we'll ever fix that. I think we're pretty solid in our job security for a long time. But some ways to pull coding and CDI and the physicians together to make sure that we are coding compliantly. And hopefully meeting the payer's requirements, but who knows at this point. It really is kind of a moving target. So probably my favorite quote that I've heard when it comes to sepsis came from John Elion. He's a physician, founder and CEO of Chartwise Medical Systems, and he does a lot with clinical documentation improvement. And I had the pleasure of listening to him speak about a year ago, and the quote that he gave was just so classic, and it was, "Sepsis is like pornography. I can't define it, but I know it when I see it." And I think that that really exemplifies the issue that we have with documentation and coding of sepsis. What we know sepsis is it's not a specific illness. It's not something I can nail down. I can't do a chest x-ray like I would for pneumonia and say, yes, definitively this patient has sepsis. Even though they have positive blood cultures, they may not truly be sick or septic. So there's just not one test that is going to help us get down to that definition of sepsis or that diagnosis of sepsis. We do know that it's a syndrome, which means that there are a lot of different things coming together, signs and symptoms, and there are specific things that are present in a patient with a suspected infection. And as I mentioned, there's no test for sepsis, but what we do know is that it is the primary cause of death from infection. And I think I posted something recently on my Facebook page, something about sepsis, and I had several people who are not in the coding field, who are not my coding friends, commenting and saying, you know, this is what took my mother, or this is what took my uncle, or whatever. So it is something that reaches very far, and it's something we're all very aware of. Now, what we're trying to do is really identify that sepsis, define sepsis as something that requires emergent identification and treatment. And it needs to be treated immediately because of that risk of death. So let me find my mouse. There we go. Somebody mentioned documentation discrepancies in their comments before we got started today, and I thought this looked kind of familiar. You know, you have 4 different doctors, and patients who are potentially septic are seeing a lot of physicians, and then you get into that issue of you know, one doctor is calling it sepsis, another calls it septicemia, and those two are interchangeable in ICD-10, but then you get somebody throwing in bacteremia or even SIRS, or maybe you're not even lucky to get sepsis or septicemia documented anywhere in the chart. It's only bacteremia or even SIRS. So just a couple of reminders for you. First of all, urosepsis, hopefully that's something that we have stamped out of physicians' vocabulary, although I wouldn't count on it. You might still be seeing that. It is something that is uncodable in ICD-10 and does require a query. But what I've been hearing from some of my auditing friends is that we are seeing SIRS documented, even though in ICD-10 SIRS is not an infectious condition. And there's even a coding clinic from third quarter 2014 that said that if you have SIRS due to an infection without mention of sepsis, you really cannot assume that that patient has sepsis. And it's unfortunate because we have spent so much time drilling that SIRS terminology into physicians' heads, and now all of a sudden we're telling them that they can't use that to mean sepsis anymore, or SIRS with infection is not sepsis. So let's take a step back and figure out how we got to where we are. And I don't code sepsis every day. So when it came time to put this presentation together, there has been so much written on this topic over the last year that I wanted to present you with the big picture without killing you with all of the details. What do you really need to know as a coder? What you should know is that there are 3 definitions of sepsis out there right now: sepsis 1, sepsis 2, and sepsis 3. The initial definitions for sepsis 1 were developed in 1991, and at the time they were just sepsis definitions. Well, those were expanded in 2001, which is about the time I started doing DRG audits, and they called those sepsis 2 criteria. And with this, we have this list of clinical criteria that define sepsis as a systemic inflammatory response to infection. And that systemic inflammatory response is why they're calling it SIRS, because that's what SIRS is. And they're saying if the patient has 2 or more of these criteria, that the patient has sepsis. A temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate greater than 90 beats per minute, respiratory rate over 20 per minute, and a high white blood count. The problem with that is that you can have somebody who meets this criteria because they have another infection, but they don't really have sepsis. Remember, that definition of sepsis is I can't define it, but I know it when I see it. And we'll talk a little bit more about that as we progress here. So with the sepsis 2 guidelines, they also had a definition for severe sepsis, which is sepsis complicated by acute organ dysfunction. And that can be something like acute renal failure, acute acute respiratory failure, or septic shock. And septic shock is a further progression of severe sepsis. So you can have severe sepsis without septic shock, but if you have septic shock, you are severely septic. Those two are not separated out. And in the ICD-10 codes, we actually have septic shock as part of a severe sepsis code. And with the septic shock, that's really the worst possible thing that we could have with sepsis, where you have hypotension that persists even with adequate fluid resuscitation, and medications just are not taking care of it. Now, there are some issues with the sepsis 2 definition. And if you find this stuff interesting and you want to figure out why they changed the coding guidelines, there was a great article in the Journal of the American Medical Association in 2016. I believe it was published in April. That reference is cited on the reference page at the end of this presentation if you want to go and read it. And it was from a group of physicians who were on the panel who decided the new sepsis 3 criteria. And this is what they're saying is wrong with sepsis 2. And that's the current definition that we use. First of all, they say that there is an excessive focus on inflammation, that we're so focused on the body's response to this inflammation, and looking at it as a continuum, as sepsis leading to or progressing to severe sepsis and then septic shock and potentially death. And they are now saying, as they learn more about sepsis, that that is not what it is. It is not a progression. It is a life-threatening condition in and of itself. So then, of course, there are all of these definitions that are being thrown out there. Physicians are definitely getting inundated with queries, and everybody's confused about what the criteria is and how they should be reporting it. And so we don't know if our reporting is accurate because the definitions are so, wonky and nothing is really solid. And they also are saying with the sepsis 2 definition that the term severe sepsis is actually redundant because a patient who is truly septic has acute organ dysfunction. They've moved past that, inflammatory response to the point where it is now a life-threatening condition that is impacting their organs. So very briefly, the new definitions for sepsis 3 were introduced in 2016. I believe it was in April of last year that this was introduced with the JAMA article, and then also at a symposium, I believe. So they define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. That sounds like severe sepsis to me. And they are saying that organ dysfunction is identified by an increase in the sequential sepsis-related organ failure assessment score, which they're calling a SOFA score. I am not going to go into detail on what a SOFA score is or how to calculate it here. There are tools out there for physicians to use, but know that it is a very complex tool that involves getting labs, and it's not something that allows for fast diagnosis of sepsis. And because of that, because some of these patients are life-threateningly ill and we need to get them treated immediately, they developed a quick SOFA score, which is QSOFA, and that can be used at bedside, no labs, to very quickly diagnose patients who are in critical condition. So with this definition, they also define septic shock, which is sepsis with persisting hypotension requiring vasopressors to maintain a mean arterial pressure greater than or equal to 65 and having serum lactate level over 2, even with adequate volume resuscitation. Now, as a coder, Why do I care? I care because I'm probably getting denials coming back to me saying, from the insurance company saying this patient doesn't have sepsis. And I'm saying, well, I'm looking at the record and the doctor says the patient has sepsis. So what am I supposed to do? And that's part of our dilemma and what we're going to talk about today. So here are a couple of sepsis coding facts. And this graphic follows sepsis 2 criteria, which shows sepsis as a continuum starting with localized infection leading to bacteria in the blood, and then that leaks out of the blood vessels and you get organ dysfunction, and then that can progress to death. And that's how our codes are set up to code for sepsis 2 criteria. Even though they came out with new criteria a year ago, we have seen no movement from the World Health Organization or from the Coordination and Maintenance Committee to update our sepsis codes to get them in line with the new sepsis 3 criteria. The other thing that we know is that we can't code from clinical criteria. There was a new coding guideline that was introduced last October that said that provider documentation of sepsis is coded as sepsis, and we cannot look at clinical indicators and say, hey, you know what, this patient has this condition or doesn't have this condition. We also know that auditors are looking at clinical criteria when sepsis is coded. It's happening with the RACs, it's happening with other payers. Septic patients are really expensive to treat, so they don't want to pay for them if they don't feel that they're really septic. And then we have a provider documentation of sepsis with organ dysfunction is coded as severe sepsis in the way that we code now. Now, I had several years ago, I had somebody send me an email, and she was going to coding school, and she said, you know, I'm really confused by these sepsis coding guidelines, and I'm really not getting this, and I don't understand. And I said, well, you know, welcome to the club, because you picked like the hardest topic for us to code. And even with the coding guidelines, you may look at it and think, okay, yeah, it makes sense. I know how to do this. But then you pick up a record and trying to determine a principal diagnosis and nail down whether or not sepsis was present on admission, if sepsis was really present, it's very tough to code. I don't like to code sepsis charts. I like to give those to somebody else. I'll take all the heart charts and give all the sepsis charts to somebody else. So we're in limbo right now because we don't really know what physicians are doing. Maybe you know in your facility, do you know if your clinicians are applying sepsis 3 criteria? And how do you apply sepsis 3 documentation to sepsis 2 codes? So a couple of things. There's a great article published by ICD-10 Monitor just a couple months ago, back in April, called Making the Leap to New Sepsis Criteria. And this is also cited on our reference page if you want to go back and read this in more detail. And I thought it gave some good tips to what to do while we're in limbo, while we have this coding system that doesn't meet the definitions that we think our physicians are starting to use. First of all, they recommended using coding audits to educate stakeholders. You know, you can't really figure out how to fix a problem if you don't go in and do an audit and see what your documentation looks like, what your coding limitations are. And then they also recommended pre-bill sepsis reviews, which I think is a great idea. You know, not every hospital has the ability to hire somebody to review all of this sepsis stuff before they go, but you can use peer reviews, coder-to-coder reviews, and I always kind of liked that because it feels less punitive to me, because you know, I've got my friend coder over here, Susie. It's like, hey Susie, will you just take a look at this, because I think I coded this correctly. I think that this fits what I need to code for sepsis, but could you just double check? They also, some other things that I'm recommending that you do are review clinical validation denials with all of your stakeholders. And this means getting somebody involved from your medical staff. If you have a physician champion who works with your CDI team, hopefully you have a CDI team, that's really kind of a good way to start getting that message out, is that, hey, you know what, we're starting to have problems with these things coming back, and how can we strengthen our documentation or really validate that these patients truly are septic. And then use or strengthen the relationship between coding and CDI. I've seen it work both ways in facilities. In doing our education for ICD-10, we worked with a lot of CDI teams who came in with coders during training, and I saw stronger teams being built because of that, and they were starting to talk to each other more and rely on each other more. Coders relying on the CDI's clinical expertise, and CDI relying on the coder's expertise. And then again, consider those peer reviews on all sepsis charts before they go out the door, just to have a second pair of eyes on it and make sure that it really is matching what's out there. So this is going to lead us to our first polling question, and there's no right answer to this. I just want to know what you guys are seeing. So Kathy, would you open up the poll for us, please?
Absolutely. So the first polling question is, are your physicians using the new sepsis 3 criteria to diagnose sepsis? So boy, you guys are quick. So we've got responses coming in. Like Christy said, there's no right or wrong. It's just, let's see where everybody's at. So are your physicians using the new sepsis 3 criteria to diagnose sepsis? So I'm waiting. Yep, we're still tallying in. Results are coming in. I have my little goals. I always set to at least have 80–90% of you responding. So we're getting close. So this is a good one just to see, and I'll tell you, we have answers all over the board. So there's no right or wrong. Feel free and just submit a response, and then we'll let Christy talk about it. So Christy, I'm going to close the poll. 3, 2, 1. And the responses are Christy. So we have 10% of our audience is saying yes, the physicians are using the new sepsis 3 criteria. We have 30% who are saying no, and we have the majority at 60% are saying I don't know.
Wow, very good. I really am not terribly surprised by these results. I did expect most of you to say you weren't sure, so I'm going to give you a little bit of homework and see if you can do some digging and figure out how your physicians are looking at sepsis in this day and age. For those of you who say no, I'm also not surprised. I don't think that physicians are always super quick to adopt when something new like this comes out. It'll be interesting over the next couple of years to see what happens with this. And 10% of you said yes, which is very interesting and definitely makes your coding a little more complicated. And hopefully you find the rest of our presentation today useful. Thank you, Kathy. You can close the poll. And we are back to our presentation. All right, coding with sepsis. This is the basic part, and I apologize for this for everybody who's an experienced coder. But what I've found is sometimes we get so hung up on the complex stuff we forget about the basics, and it's good to kind of bring it all back to the beginning. With coding sepsis, we always start with the sepsis code, and in all of our coding guidelines that refer to sepsis, they talk about the underlying condition. Code the underlying condition first, or the underlying infection. That is the sepsis. When they talk about the localized infection, that would be the pneumonia, the UTI, or whatever. So you kind of have to get used to that guideline terminology. And you code to the organism if specified, and we have a couple of examples here. Some combination codes. Sepsis due to MRSA is a combination code, A41.02. Candidal sepsis is also a combination code, B37.7. And then for those unspecified organism sepsis, we have A41.9, which also happens to be our default sepsis code. And that becomes important when we get into coding viral sepsis, because that A41 code kind of falls under a bacterial category, and it has confused some people. So Coding Clinic did come out in third quarter of 2016 with a very long article. I recommend going back and reading it and making sure that you're comfortable and familiar with how to code for viral sepsis. If you don't want to go read it now, tuck that in the back of your brain and say, oh, I remember there was something about that in Coding Clinic, and make sure that you review that before you code a case with viral sepsis. So they do talk about viral sepsis requires at least 2 codes, and your first code is going to be A41.89, which is sepsis, and that says unspecified organism, but actually it's other specified organism. And then you're going to assign a code for that viral condition. This is where you've got to be careful, and this is where we have seen a little bit of discrepancy in our audits. We have patients who the physician documents them as viral sepsis, or they'll say the patient has sepsis due to viral syndrome. Notice they code differently. And the reason they code differently is because viral sepsis, you would look under virus to get your viral code, and it gives you other viral agents as the cause of disease is classified elsewhere. But there is a specific code for viral syndrome, and it is different from just that regular virus code. So be careful, make sure that you're looking at indexing carefully, verify encoder pathways. I know that a lot of you are using logic-based encoders. There's nothing wrong with that, but this is one of those areas where I would open up that book-based encoder and just verify that you're getting to the right area. I put a couple of very simple examples here. That Coding Clinic goes into a lot of other examples, including sepsis with influenza and some other very specific viral conditions. And again, just make sure that you read that. As for bacteremia, oh my goodness, bacteremia. Bacteremia is an abnormal lab finding, and it just is the presence of bacteria in the blood. And in ICD-10, this codes to the signs and symptoms chapter. It's an R78.81. And then there's that fun little, in our thought bubble here, that little indentation under that that says with sepsis, see sepsis. So bacteremia with sepsis is sepsis, but what happens when the physician doesn't ever document sepsis? So a patient with true bacteremia who is not septic is asymptomatic, because remember, sepsis is a life-threatening condition. If they have bacteria in the blood and they do not have a life-threatening condition, you're probably safe with the bacteremia code, and I would not worry about going to ask the physician if the patient has sepsis. But it does open up for a potential query. You know, if the physician documents bacteremia, but this patient really sounds sick, then you want to go ahead and send in that query. A couple of examples. So we have this patient who's admitted with fever and dysuria. Urine and blood cultures are taken, and both are positive for E. coli. And the final diagnosis is E. coli UTI and bacteremia secondary to E. coli. And the patient was discharged home on antibiotics after a 2-day stay. Now remember what Dr. Leon said. I can't define it, but I know it when I see it. This is a 2-day stay. This patient probably is not septic, because people who have true sepsis don't get better in 2 days. You don't go from life-threatening illness to discharge okay in 2 days. This one, I would not query the physician for sepsis. I would code it as shown here with the N code for my UTI. I would add my bacteremia code as a secondary, and then don't forget to add a B code to show that E. coli as well. Now let's contrast that with our case number 2. This is a patient admitted with a fever of 102. He has tachycardia, dysuria, and a white blood count of 15,000. The admitting diagnosis was UTI, and he was started on antibiotics. Blood and urine cultures were positive for MRSA, and the patient's antibiotics were switched to cover for the MRSA. He slowly recovered after a 7-day stay. It doesn't say here, but he probably went to a sniff or some kind of post-acute care, and the final diagnosis was MRSA bacteremia due to UTI. It looks to me like this doctor is afraid of documenting sepsis. I think there's a pretty strong argument here, and I definitely think there's enough to build a query. And so I would send him a query. And of course, we know that when you send a query, you want to give him a lot of options, and you also want to give him the option to come up with his own diagnosis, since he's the physician. But this is what I would come up with. This patient was admitted with fever, tachycardia, and high white count. Blood and urine cultures were positive for MRSA. Please indicate the cause of this patient's symptoms. Is it sepsis due to MRSA, sepsis due to another organism, sepsis due to an unspecified organism, asymptomatic MRSA bacteremia, MRSA UTI, or other, and then asking him to please specify. And there's that fine line as a coder between finding the criteria that you need to document and making that leap to a specific diagnosis. So there is a little bit of clinical, there is clinical knowledge that coders are going to need to have. And if you, as a coder, or if you're a coding manager and you have coders who are not comfortable with this process, this is a great place to get CDI involved and have them assist the coder with building a query. Moving on to coding for severe sepsis. We have severe sepsis requires at least 2 codes, and we are still seeing people miss this on audits. I cannot say this enough. You cannot have that R65.21 code without your underlying condition. You must code an A41.9 first. And I don't know where the problem is coming in. I don't know if it's an encoder pathway that's going awry. I don't know if it's coding from a book index, because if you actually go to the tabular, it will tell you that you have to code the underlying condition first under that R65 code. So your severe sepsis requires 2 code. You've got to have that A or the B code first. Remember that candidal sepsis had a B code. And your second code is the code for severe sepsis, and there are 2 different codes. You've got severe sepsis without septic shock and severe sepsis with septic shock, and then you add additional codes for acute organ dysfunction if that is documented. So another reminder, because it's so important, that the R65 codes are not standalone codes. They cannot be first listed, and the underlying infection must be sequenced first. So for those of you, the 10% of you who have physicians who are using sepsis 3 criteria, and the 60% of you who aren't really sure, how do you get around this coding guideline? And this is what we need from your physicians. Rather, if they're using the sepsis 3 criteria, they're not documenting severe sepsis. And because they're thinking that that's redundant, what we really need for them to do is tell us this is sepsis with acute renal failure or with acute respiratory failure, and give us that acute organ dysfunction and link it to the sepsis. Now remember that you can, make that assumption with the with convention. Just make sure you work with providers to ensure that your organ dysfunction is documented, and make sure that you don't link sepsis and acute organ dysfunction when another cause for that acute organ dysfunction is documented. That is a place where you will need to query in many situations, but just remember that if you have sepsis documented, you have an acute organ dysfunction documented, There's no other indication for that acute organ dysfunction. You can make that assumption it's severe sepsis based on our with coding guideline. And that is because of this index injury, sepsis with organ dysfunction, codes to severe sepsis. And it gives you the severe or the septic shock code there as well. If you're uncomfortable with that, this is your fallback. And if you ever have a payer that comes back to you and tells you that you can't do that, this is your justification right here. And it's uncomfortable. I think we're still all getting used to that whole with convention, but it is possible. So let's look at some sequencing. And this is pulled from the coding guidelines. By the way, all of this is pulled from the coding guidelines. I was just trying to also pull in some of that sepsis 3 criteria, since we're going to see more and more physicians documenting that way. Severe sepsis present on admission. The principal diagnosis is the underlying systemic infection code. Again, that's the sepsis code. Your additional diagnosis, so that would be like an A41.9. Your additional diagnosis is the severe sepsis code, the R65. Severe sepsis develops during an encounter, still codes the same way, because that severe sepsis can never be the principal diagnosis. You will always have to code your sepsis code first. So your sepsis code goes first and severe sepsis secondary. Now, this proceed with caution sign is pointing to my third example, which is a little bit of a mind switch. Sepsis and severe sepsis, both present on admission with a localized infection such as pneumonia, which was also present on admission, the sepsis code is sequenced first. The localized infection code is sequenced second, and your severe sepsis code, if applicable, is coded third. And then finally, sepsis and severe sepsis not present on admission with a localized infection such as pneumonia that is present on admission, you code your localized infection code first, then your sepsis code, and then your severe sepsis code. So that was a very quick and dirty way of looking at sequencing. Sometimes I read the coding guidelines and I'm like, why could they not just give me a picture? It would be so much easier. So let's look at a case example. And this is something that we could see on an audit. We have an 89-year-old female who came in with shortness of breath, weakness, and confusion. Automatically, if it's 4 o'clock on, you know, this is my last chart, it's 4 o'clock. Yeah, this is now my first chart for tomorrow because she's got confusion, which those are some of the hardest charts to nail down a principal diagnosis. She has a past medical history positive for COPD, chronic systolic heart failure, and hyperlipidemia. And in H&P, the patient was noted to meet sepsis criteria. Yay! The diagnosis on the H&P is community-acquired pneumonia with sepsis. Sputum culture was positive for MRSA. Blood culture was negative. Final diagnosis on the discharge summary was MRSA pneumonia. And the sepsis is only documented in the H&P. This patient was in the hospital for 10 days. So the question I have for the physician is, does this patient have sepsis? Because, you know, she was in the hospital for a long time. She sounds pretty sick. She met sepsis criteria. But how many times do you see that where it's documented on the H&P, or even worse, it's documented in the ER, and then they admit the patient and you never see it again? It makes our job very difficult. So a couple of things. DRG modeling. And first of all, this first slide, this is a two-parter. Assuming that we queried the physician and he came back and said, yes, this patient has sepsis, then we get into sequencing. And if you're being fiscally responsible, you're probably DRG modeling all of your cases to make sure when you get to a situation where more than one condition meets the definition of principal diagnosis that you're coding appropriately. Here's the problem though. We have a coding guideline that we talked about a couple slides earlier that tells us that if the sepsis was present on admission, it is sequenced first. And you'll notice in this case, coding the sepsis gives me a DRG of 871. Let me see if I can find my drawing tools here. Gives me a DRG of 871, relative weight 1.766. For those of you who are focusing on APRs, it gives me an APR of 720, a pretty good relative weight, and an SOI-ROM of 3 out of 3. If you were incorrectly applying the coding guideline that says sequence either one first, you might be tempted to put pneumonia first, which would give you a DRG of 177, a higher relative weight, an APR of 137, another higher relative weight, but still a 3 out of 3 SOI-ROM. So just remember that the coding guidelines for sepsis trump that coding guideline that says, you know, sequence either one first. In this situation, if the sepsis is present, it always gets sequenced first. And I remember reading something, I was trying to find the reference for this presentation, I couldn't find it, but I remember reading something a while back that there was a time when they thought that pneumonia rates were going down, and they were so excited that pneumonia rates were going down, and they started to really dig into it, and they realized that the pneumonia rates went down after they changed the coding guideline for sepsis. And what happened was these people still had pneumonia, but they also had sepsis, and that sepsis was the primary diagnosis. So they had to look at the data again. If you think that your data that you report as a coder doesn't matter, this is an amazing representation of how it does. So code, assuming the patient came back and said, you know what, no, the patient didn't have sepsis, then this is how we would code, and it shows the reimbursement. And this leads us to our second polling question. Kathy, would you please open us up?
I certainly will. Okay, up on your screen, you should see our next question. The patient has a localized infection and sepsis POA. Sepsis pays less. Which code is sequenced first? Is it the localized infection or is it the sepsis code? What do you think? Well, you guys are quick. Okay, responses are coming in. So what do you think? Is it localized infection or is it the sepsis code? And I have to say, everybody's all on the same page. I'm going to go ahead and close the poll, Christy. I'm going to share the results. Christy, everyone is saying, 100% of them are saying we want to code the sepsis code first.
Good job, and 100% of you are correct. So we are all on the same page, and everybody's still awake. I love that. All right, Kathy, if you'll bring us back. Thank you. So we can't really talk about sepsis without also addressing sepsis in pregnancy as well as in the postpartum period. Just remember that O codes trump everything. If the patient is pregnant or within the 6-week postpartum period, that you are going to have an O code prior to any of your A codes. There are some codes that you are not supposed to use along with some of these. So make sure that you're looking at your coding guidelines for Chapter 15 for the use of OB codes. There's also sepsis in newborns, code P36. This also includes congenital sepsis, and there is a coding guideline here that says if a condition is not documented as congenital or community acquired, the default is congenital. And that can be kind of difficult if you have a newborn who's been readmitted and is, 3 or 4 days old, and they're within that 28-day perinatal period. If the physician does not tell you it was community acquired, you have to assume that it was congenital. And there are some other guidelines there as well. Post-procedural sepsis is another area that that comes up, your provider must document a link between the procedure and the sepsis. So he needs to say something along the lines of post-procedural or post-op sepsis. And the sequencing is shown here. So we have the sequencing sepsis due to a post-procedural infection. You're going to have your complication code first, a T code for post-procedural, or it could be an O code if the patient has a sepsis following a cesarean section. Underlying systemic infection code, your severe sepsis code if it's applicable, and then any codes for acute organ dysfunction if that patient is severely septic. And again, I'm speaking in sepsis 2 criteria because that's the way our codes are set up. And I did go and check the World Health Organization's version of ICD-10, and they are still using sepsis 2 criteria in that coding system as well. Post-procedural septic shock, post-procedural infection complication code goes first, and then you have a T code for post-procedural septic shock, and then your underlying systemic infection code. And one note on this T81.12 code, this one kind of caught me off guard, because if you look under code R65.21, you cannot code it with a T81.12. But there's no excludes note for the R65.21. So I found that by digging through the coding guidelines, and that was kind of something that I learned in preparation for today. Sepsis with non-infectious conditions, there are also coding guidelines for this, and sequence these according to the circumstances of admission. I think that's always my favorite statement when it comes to coding. And assign only one code from category R65. If a patient has SIRS, systemic inflammatory response syndrome, and severe sepsis, you're only going to assign the severe sepsis code, not the SIRS code. Okay, actually I think I'm going to skip this one because I kind of went very quickly over that concept. So the question here is, in which scenario is a code from R65.2 for severe sepsis not assigned? And the answer is B, for a post-procedural septic shock. You would have one for post-procedural severe sepsis. You would have an R65.2 code for septic shock due to sepsis caused by a burn, but remember that post-procedural septic shock is that T code that would be coded instead of the R65. So let's talk a couple of targets. Is this what you feel like when you're coding sepsis? This is what I feel like when I have to audit one and give somebody advice. Sequencing sepsis and a localized infection, again, when both are present on admission, the sepsis is always principal diagnosis, which I don't expect to see on any audit from anybody attending this, because you just answered 100% correctly. And coding sepsis when the clinical indicators are not met. And there is a focus right now from payers who are looking at sepsis with lengths of stay less than 72 hours. Remember that these are patients, a patient who's truly septic has a life-threatening illness. We don't send those patients home in 3 days. That is not something that a coder can really determine, though. So what are we supposed to do? Do you have a green light, or should you proceed with caution? So this is the coder standing on this line with all these different roads and different possibilities. And you have the green light when sepsis is documented and you have the clinical criteria. If you as a coder are not really sure if it meets clinical criteria, then you should be working with your CDI team to help determine if this really should be or if it really does meet that clinical criteria. Now, where you have a yellow light and you need to proceed with caution is sepsis is documented without clinical criteria. Because the doctor says it's sepsis, but I'm looking at this case and I don't really think it meets clinical criteria, but I'm not sure. Or the clinical criteria is present, but there's no documentation of sepsis. So what exactly are we going to do? Now on this last one here, let me find my little arrow. On this last one, the clinical criteria present without documentation of sepsis, that's a query. This one is trickier. The sepsis documented without clinical criteria. What am I supposed to do? Well, with that one, what we are recommending is that you develop a team approach for coding and documenting sepsis. Your physicians document, your CDIs validate the clinical aspect, and the coders code. This is the way it's supposed to happen. Proper reimbursement and quality reporting really are going to rely on collaboration between these three areas. If you do not have a CDI team, then I would work with somebody within your facility, a physician champion, someone who has that clinical expertise. As far as supporting that sepsis code, in order to get your foolproof documentation and coding together, everybody has some responsibilities here. And yeah, physicians have a lot of responsibilities, and I know they hate documenting stuff. That's not why they went into medicine. But what we need for physicians to do is thoroughly document their thought process. What got him to believe that this patient truly is septic? Not just a list of clinical indicators, but what's going on with this patient? They need to document sepsis. So if they believe the patient has sepsis, they need to document it. And they need to document acute organ dysfunction when it's present, and tell us if that acute organ dysfunction was not caused by the sepsis but was caused by something else. It sounds like a lot. All we're asking physicians to do is write down what they're thinking. You know, it's kind of like a show your work thing in math class. I always hated showing my work. I'm not a math person. You know, I have to show how I arrived at the answer. That's what we need from the doctors. CDI's responsibilities for validating that sepsis, determine which sepsis criteria is being used. Is it sepsis 2 or sepsis 3? And discuss those cases that are ambiguous with providers and help them to strengthen that documentation so that by the time it gets to the coder is coding sepsis when it's documented, but it's been backed up by our team. And they're looking for and coding acute organ dysfunction and coding severe sepsis unless another cause is documented, and querying the provider when the documentation is ambiguous or inconsistent. Now, we really hope that the queries are being done from the CDI perspective, but things fall through the cracks. Things happen, we get it. The coder is kind of that second level of verification before the final codes go out. So this leads us to our last polling question, and this is for me. I want to know what you guys do. So Kathy, could you wrap us up with this last polling question, please?
Certainly, Christy. Okay, last question. Christy wants to know, how does your organization address conflicts between provider documentation and clinical criteria? So are you coding what the provider documented? Are you coding according to clinical criteria? Are you referring the case to CDI? Other, or you don't know? And answers are rolling in great, because this will really help Christy get some perspective of what you guys are struggling with, but then also lead us on to some good discussion. And I got to say, you guys are really telling in the responses, and we have responses kind of all over the place. So please let us know. How are you addressing these conflicts as they come in? Great. Christy, the responses are still coming in fast and furious, so I don't want to close it yet.
Well, while those answers are still coming in, I will mention that just yesterday, ICD-10 Monitor published a great headline article from a couple of my colleagues from Dotsie Baxter and Linda Messmer here at the Haugen Group, and it was about this clinical criteria versus coding conflict. And if you've not had the chance to read that, it's not in your presentation materials because it just came out yesterday, but go read it. Okay, so I see the results here, and we have A lot of people, so 38% say code what the provider documented, 46% say they refer the case to CDI, and 17% say they do other. And I'd be interested to know what that other is. If you want to share with me, my email address is at the end of this presentation, and I'd love to hear from you. But I like what I'm seeing here. There really is no right answer, but I was really hoping that nobody said they coded according to clinical criteria, because we do have that coding guideline that says we can't do that. I think referring to CDI, the case to CDI, is awesome. For those of you who are coding what the provider documented, I'd just be aware that and look at the denials on the back end to make sure that your payers are paying those, and see if you might have any issues with denials. All right, Kathy, if you'll send me back to my presentation, we can get finished up. And I'll also say that if you have questions at this point, please feel free to start typing them into the chat window. I know I'm getting very close to my time, but I would still like to address questions. So a couple of tips for coding sepsis, all things that I've mentioned throughout this presentation, but just a couple of reminders that the sepsis condition always goes first due to a localized infection, as long as they're both present on admission, and that post-procedural septic shock has a T code, and we don't use the R code for that. And code according to provider documentation, not clinical criteria. Make sure that you are getting your CDI team involved, and be ready to address insurers and auditors who are looking at clinical criteria, because that seems to be the latest trend. You also want to develop, I would recommend you develop a sepsis documentation task force in order to make sure that you have a unified approach between documentation, coding, and billing, and make sure that you're getting all of your requirements met. And these are some of the team members that I recommend having there. Coding manager or lead coder. I would highly recommend, if the coding manager is there, you also have somebody who's in the trenches seeing this documentation firsthand. A CDI specialist. A physician champion is always helpful when we're doing something that has to do with documentation. I would also invite somebody who's working with core measures, because this is going to impact your core measures. You may want to involve your business office, because they're the ones monitoring denials. I would alert the compliance officer, because you are going to be looking at things that potentially are going to be audited and are compliance risks. And always, 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 I recommend having an administrative representative, because it's almost impossible to make change if you don't have administrative backing, whether it be your CIO or your COO or CFO, whoever it is. Make sure that there's somebody in your corner to help back you up and try to push some of these things through from an administrative perspective. And focus on process improvement. Evaluate your query process. Make sure that your queries are effective, and not just CDI queries, but coding queries. And what becomes part of your permanent medical record. In a lot of places, CDI queries are not part of the permanent medical record, but coding queries are. Are you only going to query to increase the DRG? I wouldn't recommend that. I would recommend querying for accuracy. And audit your coded claims. I still recommend that pre-bill peer review of all claims with sepsis codes, but also that post-billing audit to ensure that your claims were paid appropriately, and monitoring denials as well. And identify any missed query opportunities that you could learn from and then improve in the future. And then finally, I would track those metrics and evaluate improvement. Look at your denial rates, look at your core measures data. Make sure that you really are making some improvements, and it's not just additional busy work for everybody involved. And that wraps up my presentation for today. I do have our list of references here if you want to go back and read some of the things that I read to put together this presentation. And thank you very much. Uh-oh, Kathy,
Perfect.
oh, am I going too fast?
Oh, you're doing just fine, Christy. And yes, we did have a question come in, so I did want to respond to her. So we had a gal who wrote in, our physicians use sepsis 2 criteria. They say that is what CMS has adopted.
Well,
I guess that's more of a statement than a question.
That's not completely untrue, actually. CMS is one of the 4 cooperating parties, and our codes follow sepsis 2 criteria. So as you saw in the presentation, you can trace sepsis 3 criteria back to sepsis 2, but I would still, I mean, it's not necessarily an incorrect statement. It's kind of true.
Boy, that must be coder language. Kind of true. Okay.
Kind of true.
Okay, and then we had one more question came in, Christy. Okay, they mentioned you showed an example of an index term for septicemia, and it said meaning sepsis, see sepsis. Is this as opposed to septicemia without any indications or other documentation of sepsis?
You know, it is kind of a strange index entry, but based on the default code, septicemia codes to A41.9, which is sepsis, unspecified organism. So in ICD-10, the terms sepsis and septicemia are interchangeable.
Okay. Well, thank you, Christy. That's all of the questions. At this time, I want to thank Christy for your wonderful presentation, and then I want to thank our audience for, again, attending one of our webinars. Up on the screen, there has been some questions, so I just kind of wanted to show this to you. You will receive a follow-up email within approximately 2 days, and in that email, you will have the link to the webinar recording from today, as well as all the materials. And the materials will contain the handout, the PowerPoint presentation. It will also contain the CEUs for attendance. There will also be a test, and that is only needed if you are only recording the if you are only viewing the recorded and not the actual live event. That's so you can get AAPC CEUs. So, and then of course the link to the survey. So, any questions, feel free and contact us or contact Christy. We want to thank you for your time, and that concludes today's webinar. Have a great day. Bye-bye.